So friends, let us now discuss the Eustachian tube. Okay, so let's discuss the anatomy of the Eustachian tube. This Eustachian tube, we also call this tube as auditory tube or pharyngotympanic tube. Okay, this tube connects the pharynx to the tympanic cavity. Which part of pharynx? It connects the nasopharynx. Okay, the lateral wall of nasopharynx to the tympanic cavity. Okay, so which part of tympanic cavity? Anterior wall of middle ear. Anterior wall of tympanic cavity or anterior wall of middle ear. So that is connected to the lateral wall of nasopharynx. Okay, so it is also known as pharyngotympanic tube. All right, you can see over here we have this Eustachian tube. It is approximately 36 millimeter in length. All right, so this Eustachian tube is approximately 36 millimeter in length, and this Eustachian tube is approximately 1/3. The lateral 1/3 of this is bony. The medial 2/3 of this is cartilaginous. Okay, so lateral 1/3, that is the part near the ear, is bony. The medial 2/3 is cartilaginous. Now, the narrowest part of the Eustachian tube is known as isthmus. Where is this isthmus? Remember, in the EAC also, the narrowest part was known as isthmus. Here also it is known as isthmus. Now, this isthmus is at bony cartilaginous junction. Right? Okay, it is at bony cartilaginous junction. Also remember, this cartilaginous end of Eustachian tube, it slightly protrudes into the nasopharynx. Okay, so this cartilaginous end of Eustachian tube over there is known as torus tubarius. So what is torus tubarius? Torus tubarius is the cartilaginous end of Eustachian tube which is protruding into the nasopharynx. Right? Okay. Now, this Eustachian tube is at an angle of 45 degrees to the horizontal plane. Okay. What angle? 45 degrees to the horizontal plane. Right? Remember, we talked about the EAC and the tympanic membrane. The tympanic membrane forms an angle of 55 degrees with the anterior inferior wall of EAC. Now, this Eustachian tube is at an angle of 45 degrees to the horizontal plane. Okay, in case of neonates, remember, when a child is born, in newborns, this Eustachian tube is almost horizontal. Okay, the Eustachian tube is almost horizontal, and the tube length is almost half of it. It is around 16 to 18 millimeters at the time of birth. Okay, so 36 half is 18. You can see it is half the length of the Eustachian tube at the childhood stage. Therefore, you see the Eustachian tube grows from this size to the adult size. So therefore, in case of children, because the Eustachian tube is horizontal and it is shorter, the infection can quickly travel up from the pharynx to the middle ear. So the Eustachian tube is shorter and more horizontal. So the children are more prone to middle ear infection. All right, okay, right, let's see over here. This is the Eustachian tube, and we can see that this over here is the tympanic, the middle ear orifice, the middle ear opening, which is 5 millimeter by 2 millimeters, where we have a broader opening in the pharynx, okay, which is 8 millimeter to 3 millimeter. That's not very important, these dimensions. What is important for us is this length and the isthmus, the narrowest part of the Eustachian tube. This is approximately 3 millimeter in length, and this is the part where we have the junction of bone and cartilage. Okay, right? The next thing I taught you, the infant Eustachian tube is shorter and more horizontal. Okay, therefore, chances of infection traveling from the pharynx to the middle ear is higher in children. Right? So, children are more prone to middle ear infections. All right. Now, let's look at this. Osman's pad of fat. Now, this pad of fat, the Osman's pad of fat, Okay, it keeps the eustachian tube in a closed position. So remember, the eustachian tube is closed at rest, and that is because of Osman's pad of fat. So you can see over here the cartilage, the elastin cartilage, okay, and you can see the muscles attached. We have levator villi palatini and we have tensor villi palatini. Now, these two muscles are over there attached to the eustachian tube. The tensor villi palatini, this is the main opener or main dilator of the eustachian tube, okay. The medial fibers of tensor villi palatini, they are the main openers of eustachian tube. They are therefore also known as dilator tubae. Okay, so they are also known as dilator tubae. You see what happens when this tensor villi palatini contracts. So now when this tensor villi palatini contracts, what happens? It pulls this cartilage of the eustachian tube anteriorly, and that leads to opening of the eustachian tube. Okay, so as you can see over here, this forward pull has led to opening of the eustachian tube. Now the levator villi palatini over here, it supports the eustachian tube, so it is able to open. So you see, some function, secondary function of the levator villi palatini is opening the eustachian tube. Okay, because it holds the eustachian tube here so that the tensor villi palatini is able to open it up. But the main opener, the main dilator of the eustachian tube is tensor villi palatini. Okay, let's look at this tensor villi palatini. So we can see the eustachian tube over here. All right, and it is opening into the lateral wall of the nasopharynx just behind the nasal cavity. Right, and we have the levator villi palatini and we have the tensor villi palatini attached to the anterior surface. And when this tensor villi palatini contracts, it opens the eustachian tube. Look at this tensor villi palatini. It goes down, it takes a turn at the pterygoid humulus, and it will go and attach to the other side tensor villi palatini in the center, in the soft palate. Okay, so over here in the soft palate, the tensor villi palatini attaches. We can also see the other muscles in the soft palate. We can see the palatopharyngeus and we can also see the palatoglossus also over here. Okay, so these all together they form the soft palate. So therefore, if there is a patient who has cleft palate, okay, so there is a patient who has a cleft palate. Now these muscles, they are not able to meet in the center. So because they are not able to meet in the center, that means the center part is free. So when they contract, nothing will happen. Okay, so therefore patient will have eustachian tube dysfunction. So patients of cleft palate have eustachian tube dysfunction, and that may lead to middle ear problems, middle ear disorders. Okay, so eustachian tube dysfunction may cause a lot of middle ear disorders. Now, what are the functions of this eustachian tube? What are the functions of eustachian tube? Why it is important for us? Why its disorders can affect the middle ear? So functions of eustachian tube. Number one function, it maintains middle ear air pressure. Okay, it maintains middle ear air pressure. How much? Equal to outside atmospheric pressure. Okay, equal to outside atmospheric pressure. So it maintains middle ear pressure. Now remember how it maintains middle ear pressure. Normally it is closed at rest. Okay, so but when you yawn, when you swallow, now what happens at this time? The soft palate moves, and that leads to contraction of your tensor villi palatini, and that opens the eustachian tube. So the air enters into the middle ear and the air pressure is restored. Now the advantage of this close at rest, what is the advantage of this? The advantage of this is it prevents the food and the infection, okay, from going into the middle ear. Okay, so prevents food or the infection or liquid to enter into the middle ear. All right, so it is closed at rest. All right, now another function of the eustachian tube is that it drains middle ear secretions. Okay, so this eustachian tube, it drains middle ear secretions. Okay, now because of this arrangement of the middle ear and the eustachian tube, something particular happens. You see, the middle ear is lined by mucosa. Okay, so the middle ear, you see, it is lined by mucosa. And it is almost a closed cavity, almost, not completely, but almost a closed cavity. Okay, it keeps on receiving air from the eustachian tube. Now, the mucosa has a property that it absorbs oxygen from the atmosphere, from the surface. Okay, so it absorbs air from the surface, or particularly you can say that it absorbs oxygen. So there is a gas exchange that takes place at the surface of the mucosa. Okay, so it will take in oxygen, it will give out carbon dioxide. Right, so that means in the middle ear air, if we talk about the middle ear air will have more carbon dioxide and less oxygen as compared to atmospheric air. Okay, so they have maintained a different atmosphere inside the middle ear. What is the advantage of this? Now the advantage of this is that low oxygen will not allow growth of these aerobic bacteria. Okay, so these aerobic bacteria, they are not allowed to grow inside the middle ear. So therefore, the middle ear is maintained as a sterile environment. Okay, so all this arrangement has made the middle ear as a sterile environment, does not allow the growth of aerobic bacteria so quickly. Okay, if there's a tympanic membrane perforation, if there's a hole in the tympanic membrane, now this is lost. In that scenario, this whole thing is lost, the high carbon dioxide, the low oxygen, that is lost. And therefore, chances of infection are more, the growth of bacteria is more if we have a tympanic membrane perforation. Alright, okay, now that was the eustachian tube anatomy. Let us now discuss the different tests, how we can check whether the eustachian tube is properly functioning or not. Okay, so let's do the eustachian tube function tests. Right, now the eustachian tube function tests are of different types. First, let us discuss the passive test. What do I mean by passive test? Passive test you can also say as non-physiological tests. Okay, so non-physiological test means you are just checking whether the eustachian tube is anatomically all right or not. Okay, you can see whether it can be opened or not, but you don't know whether the muscles are acting, whether physiologically it is functioning or not. So these are non-physiological tests. The first passive or the non-physiological test is your Valsalva maneuver, Valsalva test. So as you can see in this photograph, what is done? You ask the patient to close the nose and blow the cheeks. Okay, so as you can see over here, this patient, she is blowing the cheeks. So what happens as a result? As a result of this, a positive pressure is generated in the oral cavity, oropharynx, nasopharynx. Now the nasopharynx positive pressure forcefully opens the eustachian tube. Okay, so it will forcefully open the eustachian tube, the air will go into the middle ear and the tympanic membrane will bulge out. Okay, so you can see I am looking at the tympanic membrane. So as soon as the patient does Valsalva, I can see the tympanic membrane bulging out. Alright, so that tells me that the eustachian tube is anatomically alright, it can be opened by this positive pressure. But this is a passive test, non-physiological, because the eustachian tube is not being opened by muscles but by positive pressure in the nasopharynx. Okay, so that's the Valsalva test. Okay, now children are not able to do the Valsalva test. So what we can do in them? In them we can do Pulitzer test. So what is this Pulitzer test? The Pulitzer test contains a Pulitzer bag. So now what you can do is, you can put this bag in one of the nostrils, you can put the tip of this bag and then you can close the nose, you can ask the child to keep the mouth closed and then you can press the bag. So when you press this Pulitzer bag, now it will give a positive pressure in the nose and the nasopharynx, and this pressure will go to the eustachian tube. It will open the eustachian tube. Again, you can observe in the ear and you can see that the tympanic membrane bulges out. Okay, so that is your Pulitzer test. It is done in children, especially who are not able to perform the Valsalva maneuver. Right? Okay. Next, well, we can also do the Eustachian tube catheterization. So now what is done in Eustachian tube catheterization? See, this is a Eustachian tube catheter. Okay, this may be asked if you are an undergraduate student, this may be asked in your exam viva. All right, so this is a Eustachian tube catheter. So how do you identify the Eustachian tube catheter? You see, it looks like a suction cannula. It has a hole, it's a pipe. Now, there are some important features which differentiate this from a suction cannula. Number one, you will see that there is a soft ending over here with a slight bulge. Okay, so soft rounded ending with a bulge. Number two, this has a turn. Of course, we have seen that there is a curve over here. Now you notice that on this end, okay, you can see that there is a ring. The ring tells you on which side the turn is present. So this ring will be present on the same side as the turn. All right, so this is a Eustachian tube catheter. Now, how we do Eustachian tube catheterization? So you take this Eustachian tube catheter and you insert it straight into the nasal cavity, keeping this end down. So how do you know this end is down? You will keep looking at this ring because the other end has gone into the nasal cavity. You cannot see it. You can see only this ring. So this ring will tell you where the other end is, in which direction. So keeping this ring down, you put the Eustachian tube catheter into the nasal cavity and pass it along the floor till the nasopharynx. Okay, so let's say my finger is the Eustachian tube catheter and now you pass it along into the nasopharynx. And now after that, what you do? You rotate it medially. Okay, so you rotate it medially. All right, so medially you rotate it and you pull it back. So when you pull it back, now what will happen? This turn, this will engage behind the nasal septum. Okay, so you pull it gently, it strikes the nasal septum, you cannot pull it any further. All right, now at this place, you rotate it by 180 degrees. Okay, so you rotate it by 180 degrees and then you can enter into the Eustachian tube like this. Okay, so this is how we do a Eustachian tube catheterization, and then over here you can attach the Pulitzer bag and you can blow open the Eustachian tube. All right, so this is the third way you can do. You can blow open the Eustachian tube by this Eustachian tube catheterization. Once again, you can see whether the tympanic membrane is bulging out or not by an otoscope, and that will tell you whether anatomically the Eustachian tube is all right or not. So all these three tests, you see, we are forcefully opening the Eustachian tube. Let's come to now active tests or the physiological test. So the active or the physiological test is the Toynbee test. So what is done in Toynbee test? You see over here what the patient is doing. She has closed the nose and now she is drinking water. Okay, so against a closed nasal cavity, she takes some water, keeps it in the mouth and swallows it. So now this swallowing generates a negative pressure. And the action of swallowing, see, not only generates a negative pressure against the closed nose, the action of swallowing will lead to contraction of tensor villi palatini, and that opens the Eustachian tube. So now, the negative pressure of the nasopharynx and oropharynx will pull the air out of the middle ear. So now the tympanic membrane is retracted. So remember, now you will see the tympanic membrane. This tympanic membrane will be retracted and that will show the Eustachian tube is working. This is a physiological test. Why? Because the Eustachian tube is being opened by the negative pressure. Okay, so remember, Toynbee test is a physiological test. Another physiological test is tympanometry. You can also call it as inflation deflation test. Okay, now what we do in tympanometry, I will be talking about tympanometry in great detail later on. But remember, tympanometry, we put a probe in the ear. Okay, and on this probe, we have three things. Number one is the sound source. Number two is the microphone that receives how much sound is reflected back after striking the tympanic membrane. And number 3 is the pressure meter, with which we can increase and decrease the pressure in the EAC. Okay, so let's look only at the pressure meter right now. So with this help of tympanometry, we can look at the pressure in the EAC. We can even increase or decrease the pressure. Okay, now what we do is we keep the pressure same as the middle ear. So tympanic membrane is in normal position. We have not done anything. We are just measuring the pressure in a tympanometry. Now what we do is we ask the patient to do Valsalva. Okay, so we ask the patient to do Valsalva. What will happen? The Eustachian tube will be opened up and the air enters into the Eustachian tube and the tympanic membrane bulges out. Okay, so we know Valsalva is a passive procedure, non-physiological. The pressure in the middle ear will rise, tympanic membrane will bulge out, the pressure in the EAC will also rise, and that will be shown in our pressure meter over here. Okay, now this part is the non-physiological part. But now after this, what we will do is we'll ask the patient to do the Toynbee maneuver. Okay, so patient swallows against the closed nose. And what will happen? It will generate a negative pressure. So all the air will be sucked out. Okay, all the air from the middle ear will be sucked out. All right, and the tympanic membrane will now retract. So this part makes this complete test as a physiological test. Okay, so this is known as inflation deflation test. First we do inflation. It's very important so that we know how much deflation can be there. Okay, so it will give us a very good result, inflation, and then finally deflation test that is done with the help of tympanometry. Right? Okay, next we can also do this tympanometry test even with a perforated tympanic membrane. Okay, the same thing. You see, even if there is a perforation of the tympanic membrane, the middle ear pressure and the EAC pressure will rise when you do Valsalva. Okay, and the pressure will go down when you do Toynbee. So if a patient is having perforation, you are planning for some surgery, you can know the Eustachian tube function by doing this tympanometric test. The advantage is you can even do it in a perforated tympanic membrane. Right? Okay, now apart from this, let's come to some other tests. We can do a radiological test. Now radiological tests are generally done in perforated tympanic membrane. Okay, so perforated tympanic membrane, what we do is we put a radio-opaque dye in the middle ear, right? And then we take an X-ray. You see the radio-opaque dye from the middle ear starts traveling into the Eustachian tube, and from the Eustachian tube it goes to the nasopharynx. So you can see this X-ray and you can see if there is some obstruction, if the dye is not going into the nasopharynx. Okay, so that's the radiological test. Again, that is done for a perforated tympanic membrane. What else can we do in a perforated tympanic membrane? We can, instead of putting a radio-opaque dye, we can just put saccharin. So saccharin has a sweet taste. It will come into the throat. The patient will have a sweet taste. It will tell you that something is tasting sweet in his throat. Okay, or you can put a methylene blue dye, like in this case. You see, the dye was instilled in the middle ear, small amount of dye, and now we can see the dye coming out of the Eustachian tube into the nasopharynx. Okay, so you can even put a methylene blue dye. So all these tests are tests done in a perforated tympanic membrane. Okay, which test? Saccharin test, methylene blue test, the radiological test, and even we can do tympanometry in perforated tympanic membrane also. That we can do in both intact as well as perforated tympanic membrane. Okay, now nowadays other than these tests we have some more tests, like we have the CT scan. Okay, so we have seen the CT scan. Now you see this we saw was the middle ear, we saw the ear, the external ear, the middle ear, and now we can see over here that this part, I am now encircling this part, this is the Eustachian tube. Okay, right, correspondingly over here also we must have an Eustachian tube. Okay, so we can see the Eustachian tube by the CT scan. Now the thing to notice over here is that on the right side, this Eustachian tube is open. I told you at rest the Eustachian tube is closed. Okay, so just like on the left side, you see the eustachian tube is almost closed. There is no air. But on the right side, the eustachian tube is open. So when the eustachian tube is open, okay, at rest, that is known as patulous eustachian tube. Now this disorder is known as patulous eustachian tube. Okay, what will happen in patulous eustachian tube? The patulous eustachian tube will lead to autophony. That means the patient will hear his own voice very loud. Okay, so he'll come with this complaint of autophony that my own voice resonates. I hear it very loud. So that condition is known as autophony, and it is seen in patulous eustachian tube. Okay, other than the patulous eustachian tube, this condition is also seen in superior semicircular dehiscence. So that condition is a totally separate condition. We will be discussing it later on. All right, so this autophony is a very characteristic feature of patulous eustachian tube. Now, this patulous eustachian tube can happen because of rapid weight loss. Okay, so rapid weight loss, it can happen. It can also happen in case of pregnancy. Pregnancy, because of hormonal changes, this tube becomes dry and there can be a patulous eustachian tube. Okay, a lot of treatments have been tried, such as steroid sprays or decongestants. All right, so some of them are useful. They vary from patient to patient. Now even Teflon injections have been tried. Okay, but nowadays we don't do Teflon injections. The reason is that in a few patients, while injecting Teflon, it went into the ICA, internal carotid artery. You see, the ICA is very near to the eustachian tube. So if the Teflon enters into the ICA, if you inject a little bit, if your needle goes a little bit ahead, you may enter into the ICA, you may end up injecting Teflon into the ICA and the patient can die. All right, so this is a very big risk factor. So therefore, the surgeons nowadays, they don't like to inject Teflon near the eustachian tube. You may do some surgery and you may scar the eustachian tube, or you can inject fat around the eustachian tube. All right, so there are some of the treatments which are possible for a patulous eustachian tube. Okay, another investigation which is nowadays available to check the eustachian tube function is sonotubometry. Sonotubometry. Okay, so sono means sound, tubometry, we are checking the eustachian tube function. What we do is, in this, you can see this patient is applied headphones and there is a microphone in the EAC. And you give a sound from the nose. You can see a sound source is put in the nose. So now the sound is given in the nose, it reaches the nasopharynx. From the nasopharynx, if the eustachian tube is open, the sound signal will reach the middle ear. And then this sound signal can be picked up by a probe in the EAC. So this probe will tell you how much sound is coming, okay, how much intensity of sound is reaching and how much delay is there after the sound source. So with this, we can find out the eustachian tube and whether it is open or not. All right, so this is your sonotubometry. Okay, so this is one of the latest investigations which is used to find out the eustachian tube functions. Right? Okay, now this question, let's come to this question. It was asked in the JIPMER exam, November 17. Pulitzer bag maneuver is used to test. So we have already seen the Pulitzer test that is used to test the eustachian tube. Okay. All right. Now, before we finish the topic of eustachian tube, the most disorders of the eustachian tube are because of the obstruction of eustachian tube. Now, obstruction of eustachian tube may be because of various reasons. There may be a mass in the nasopharynx, there may be a polyp, a malignancy, some tumor. Okay, so now in those conditions you have to treat the cause. If you treat the cause, the eustachian tube will open up. Now, however, sometimes eustachian tube, because of repeated infections, it may undergo scarring. Okay, so there may be fibrosis, and because of that, eustachian tube internally may undergo a stenosis. It may close down. If it does not open, what will happen? We'll have a lot of problem in the middle ear. Now, in those chronic eustachian tube disorders, nowadays what we are doing is we do eustachian tube balloon dilatation. Okay, so once you have identified that there is a problem in the eustachian tube itself, you can dilate the eustachian tube by putting a small tube balloon. Okay, so this balloon is placed inside the eustachian tube and then you inflate, and with this you open up, you dilate the eustachian tube. Right? So this is known as Eustachian tube dilatation, balloon dilatation. Let's look over here in this small video. What we can see is we have these specific devices. Now we are putting this device under endoscopic guidance. So then the endoscope vision, you can put this device, you can take it to the nasopharynx, and then you turn this and you insert the balloon into the eustachian tube, and once it is completely inserted till that ring, then you inflate it. Okay, so when you inflate it, that will break all the stenosis, all the fibrosis, and it will open and dilate the eustachian tube. Okay, so this is your eustachian tube balloon dilatation, which is being done these days to open a blocked eustachian tube. All right. Okay, so that was about the eustachian tube, its function test, and the disorders.